Well, welcome everyone to our On the Pulse series. We're so glad to be back with a new season of offerings. I am Chris Fortman, the CEO of the Minneapolis Heart Institute Foundation, and I am so glad you made the time to join us today to hear a little bit from our physicians. And before we get into our keynote speaker, I would love to give you a little background on the Minneapolis Heart Institute Foundation. So we are an independent nonprofit research and education organization, and our great work is made possible by our unique partnership with the Allina Health Minneapolis Heart Institute. So as a research and education organization, we partner with very busy cardiologists and surgeons who have real-time questions, and we bring that all to life, and all of that work improves our clinical practice. Here are some examples of how this happens. Our mission is to improve cardiovascular health through innovative research and education. So right now we have over 200 studies underway, touching the lives of over 2,000 patients. And this is physician-initiated research and industry-sponsored clinical trials. And it's so important to have that mix and that number of studies because it offers options to our patients. In addition to the research side, we are committed to educating the community and the next generation of healthcare providers. One of our great programs is our internship program, where college students come for the summer and partner with a physician and a research staff to do real-time research and often present at conferences. Most of our alumni are either practicing physicians or currently in medical school. We also provide ongoing continuing medical education opportunities, community education, and of course are very committed to publishing all of our research findings in peer-reviewed journals, and that number is about over 200 annually. And this is a special year for us because we are celebrating our 40th year anniversary, and we've been able to continue this work for the past 40 years because you can see many of our values to the right. That's operating with innovation, ensuring impact, being agile, really leveraging our passion, always expecting excellence and quality, and most importantly, having those options for our patients. Here we have a summary slide of really what has changed from 1982 to 2022. As you can see, the aqua colors show the numbers of MHIF, the number of physicians at 13, staff at 5. And you can see where we are today with the partnership with over 100 physicians, with 80 plus staff ready to support research and education opportunities, a $16 million investment, and again, publishing more than 3,000 peer-reviewed manuscripts in this time. And the story goes on. I just wanted to share this with you because we are so excited, not only to celebrate the last 40 years, but to look forward to the future. And this is probably one of the most important slides. And this is really to say thank you. We are so grateful for the community partnership and the many people and organizations that make this work possible through their very generous philanthropic contributions. So with that said, it is time to get on to our keynote. I am pleased to introduce Dr. Santiago Garcia. Dr. Garcia is an interventional cardiologist and researcher. He is also an associate professor of medicine at the University of Minnesota. His work includes more than 100 published manuscripts in peer-reviewed medical journals. Today, he will be presenting on the COVID-19 pandemic's impact on heart attacks and acute CV events, and also give an overview of MHIF's NACME study. Following Dr. Garcia will be Dr. Manos Brillakis. Dr. Brillakis is the director of the Center for Complex Coronary Interventions at MHI and the director for the Center for Coronary Artery Disease at MHIF. Dr. Brillakis has authored or co-authored over 700 manuscripts and is lecturing and proctoring at several institutions in the United States and abroad. Today, he will be speaking on the importance of cardiac care and follow-up appointments in the setting of the COVID-19 pandemic. With that, thank you very much, and I will hand it over to today's speakers. Thank you.
Well, thank you for the opportunity to be part of the On the Pulse session today. My name is Santiago Garcia. I'm one of the interventional cardiologists with the Minneapolis Heart Institute. And today I will be discussing how the COVID-19 pandemic has affected the care of patients with heart attacks. And I'm going to go back to 2020, the early days of the pandemic, where we were all preparing and trying to adapt to this new reality of having to deal with COVID-19 and how that was going to affect our protocols, from seeing these patients in the emergency department to patients that are being transferred from other hospitals and need to get tested for COVID-19. And as we were preparing protocols also for PPE and other considerations in the catheterization laboratory, we noticed that there was a sudden drop in heart attacks early on in the pandemic. We first reported this was about 40% decline in heart attack activations in the early month of the pandemic. And so we were scratching our heads a little bit, because typically what we see with viral illnesses is that there is an increase in heart attacks, likely related to the virus itself and how that affects the cardiovascular system. Instead, we were seeing the opposite. And it's not something that was restricted to Minnesota. It was actually, we put together 7 programs in the Northeast and in the West Coast as well. And every single one of those programs saw a significant decline in heart attacks in March and early April of 2020. And this was not just heart attack patients. As we started to investigate this more, it was a sudden drop in cardiovascular emergencies in general. And to try to understand this signal and what it meant, we certainly had to go back to early 2020 when there was a mandate initially from the federal government, and then each state instituted its own rules about the stay-at-home orders. And we also, healthcare providers restricted access to clinic appointments, and we did not allow visitations, and some of those practices are still in place today. But the signal that we sent to the public was, if you have symptoms that could be consistent with COVID-19, whether it's shortness of breath, fever, or something similar, shelter in place, stay at home, don't come to the hospital. We were getting all these horrific images from New York City, hospitals being overrun, and so forth. And patients actually did what we told them to do, which is they stay home. So early on, we understood that we had to recalibrate the message and how we communicate with the public with regards to heart attack and other cardiovascular emergencies. At the same time, we saw this signal, significant decline in heart attacks. We noticed there was a significant increase in cardiac arrest at home. So this was not certainly a good thing for patients. They were having the heart attacks at home. They were not being treated. And those patients that were being treated, actually, many of them show up to the hospital very late, after 2 or 3 days of having symptoms at home. Those symptoms not getting better. So the first thing that we tried to do is understand this trend and try to reverse it. There was a educational campaign from SCI, our interventional society, try to educate patients that heart attack still is an important consideration, and is in fact the #1 killer in this country. And we saw within 2 or 3 months that we were able to reverse those trends. And that was a positive thing. The other area of research that we have explored at the foundation is what happens when COVID-19 and heart attacks coexist in the same patient. We know that after contracted COVID-19, in the first 2 weeks, there is an increased risk of heart attacks. And that association it can be lethal to a degree that we haven't seen before for patients presenting with heart attacks prior to COVID-19 pandemic. The link between these two entities is that COVID-19 tends to trigger a significant inflammatory response and activation of the coagulation cascade, and that leads not only to increased risk of heart attacks, but thrombosis in general, both on the venous system and in the arterial system as well. So patients who have COVID are at risk of developing clots in their legs, DVT, or clots in the lungs, also called pulmonary emboli. So we created a registry, which we called NACMI, a North American COVID-MI registry, that capture these patients in the United States and Canada. And now we're 2 years into this wonderful journey with NACME. And there are a few things that we learned. The first report was last year with the first 200 plus patients in the registry. We noticed that in the early phase of the pandemic, there was a preponderance of ethnic minorities in the registry. And that is unlike any other heart attack registry we have seen from the US. Most registries have a 70 to 80% Caucasian population. But the COVID-MI registry, it was almost 50-50. 50% of patients in the registry were from ethnic minorities, in particular Hispanics and African Americans. We also noticed that this association of COVID and heart attacks was associated with very high mortality. Mortality for heart attacks prior to COVID was in single digits. And with this entity, when patients had heart attacks and COVID, mortality could be as high as 30%. So that is a significant increase in mortality. The third observation that we made is there was a fair amount of controversy about how to best treat these patients. And the Chinese and others recommended a shift away from what we typically do, which is angioplasty during the pandemic, just because these patients could potentially transmit the virus to the entire team. And essentially, you have a shortage of healthcare workers to take care of patients, other patients with COVID-19 and other illnesses. In North America, we did not see that transition. We stayed, I think, loyal to the principles of heart attack management, which is timely reperfusion by means of angioplasty. And so that 75% of patients with COVID-19 and STEMI still receive primary angioplasty with a stenting, which is, I think, a very, very healthy signal from this registry that we have, despite the challenges, we have been able to provide good care to these patients. And now the most recent sub-analysis that we've done for these patients, now looking into 2 years into the pandemic, was what happened over time. The most significant development in the field has been the introduction of vaccines, and that happened commercially in late 2020 and early 2021. So we compare the outcomes of patients who were treated in 2020 versus patients who were treated in 2021. And fortunately, we have seen a significant decrease in mortality. So for 2020, mortality was approximately 33%. For 2021, mortality decreased to 23%. In 2021, we went one step further and did our best efforts to try to capture vaccine information among those patients who presented to the hospital with a heart attack. And what we found is that there was a significant difference between vaccinated and unvaccinated patients, so that for vaccinated patients, mortality was 0. So these patients had heart attack, they had COVID, but none of them died. Whereas mortality for patients treated in 2021 who were not vaccinated was quite high, still at 22%. So the message, I guess, is in 2020, mortality was very high for everybody. And in 2021, when vaccines became available, we see this signal and clear difference in outcomes of patients that are vaccinated versus unvaccinated. Patients that are vaccinated tend to have outcomes that are very similar to heart attack outcomes prior to the pandemic. Whereas for patients who remain unvaccinated, mortality remains quite high at 22% in the hospital. So that gives us an opportunity to continue to educate the public on the importance of vaccines. We also have seen that some of the trends that I described for 2020 have reversed. So that for 2021, the majority of patients are Caucasians, and there is a significant 20% decline in the proportion of patients that present with abnormal chest X-ray findings. And this suggests that these patients are having heart attacks, but they're not necessarily having all the other extra cardiac manifestations of COVID-19, in particular the pulmonary involvement pneumonias, and so forth that come with this disease, and is a significant driver of mortality. So this is a very good signal, and I think is consistent with what we know about vaccines. We have also noticed that the proportion of patients who present to the hospital with shock, these are patients that have very low blood pressure and have very high mortality rates, has also dropped significantly in 2021. So these patients are definitely less sick than what they were in 2020. And we think that vaccines have a lot to do with it. Unfortunately, of the population in 2021, we have vaccine data in about 56% of them. And there's only a minority of those patients, about 11% or so, that are vaccinated. So the majority of patients that still come to the hospital with COVID-19, with or without a heart attack, are unvaccinated. And this is consistent with other data that shows that that's what vaccines do. They prevent hospitalizations and mortality related to COVID-19 infection. So once again, there is an opportunity here to educate the public and to have a meaningful impact on outcomes as well. So the foundation has really done a phenomenal job at exploring the link between heart attacks and COVID-19. And I think we have created the largest registry in the world on this entity. And that has been very helpful to inform the community and the public about the importance of timely treatment of heart attacks, the importance of staying true to the principles of heart attack management, and that includes mechanical reperfusion by means of angioplasty. And finally, the importance of vaccines as possible mediators of better outcomes in the last, I want to say the last year of the pandemic, hopefully, but we still have to see that, obviously, going forward. Thanks again for the opportunity. Thanks.
All right. Well, again, thank you very much, Dr. Garcia. That was an excellent presentation. You've heard on ACME, it was actually a late breaker at ACC, simultaneous publication in JACC, a lot of great information of how things are changing with COVID and how we approach it in the setting of myocardial infarction. But it's not just the patients with heart attacks that need to take care of your hearts, but the other patients as well. So let's explore a little bit about why we need to be aware of the heart disease and take care of things even when we don't come in the hospital with a heart attack. This is a quote that may sound interesting now. It was written several years ago, way before the pandemic, but I thought it was particularly relevant to this. It's from David Allen, Getting Things Done. It says that something is coming, probably within a few days, I would say months or years, that is going to change your world. And you can't see it yet, you don't know what it is about, but it is there, rolling inexorably forward, and it's destined to throw you a curve that you did not expect. It could show up sooner or later, but trust me, it will show up. So the bottom line is, this is a perfect segue for COVID. No one expected it to come, but it was coming, and it's running its way, and we're not sure yet what the future has to go. But what we've seen and what you've heard from Dr. Garcia's presentation is that if you have coronary disease, so if you have known blockages in your arteries, and then you get COVID, things are much worse than if you do not. There are many studies that have shown this. This is a meta-analysis of several of them, and essentially you have a significantly higher risk of dying if you have coronary disease and then you get COVID as well. And then if you have hypertension and coronary disease, and you get COVID, your risk is even higher than that. Also, if you have coronary disease, but you don't really know about it, so a symptomatic coronary disease, but you have some blockages in the coronary arteries, and this can sometimes be seen by doing what's called the coronary calcium score. So those patients actually are going to have much worse outcomes if you have COVID than if they do not. So people who have known disease are at increased risk, but even those who do not have known coronary disease but have subclinical, as we say, atherosclerosis, they are also at risk of developing worse events if they get COVID. And there are many mechanisms why this may be happening, but the big one seems to be the hypercoagulability. So essentially, COVID increases the risk of blood clot formation in the body, And that can be in several locations. It can be in the lungs, causing pulmonary embolism. It can be in the heart, causing heart attacks. It can be in the legs, causing deep venous thrombosis. It can be going to the brain, causing a stroke. So getting this extra risk of clot formation can have adverse events in multiple parts of the body. And that is why preventing it is of the utmost importance. You've heard from the NACMI presentation that the outcomes of heart attacks are much worse in patients who have COVID. And this is potentially the reason. You have a lot of blood clots, much more so than in patients who have heart attacks without COVID, in the setting of COVID. And it's much harder to get rid of those blood clots and get the blood flowing the way it should be. So hospital mortality, as you've heard from NACMI, it is very high. It is in the range of 20 up to 70% in patients who have COVID and a heart attack. So clearly something you don't want to be in. And the sad thing is that it's not only on patients who have heart attacks because their coronary arteries get blocked, but some patients get heart attacks with COVID, even if their arteries are okay. This is the so-called STEMI with non-obstructive coronary artery disease, and thrombus embolization could be a mechanism, but we're still looking to understand what the mechanisms are for these problems. You've heard this already, so if you have COVID and STEMI and heart attacks, then your outcomes are going to be very poor. But what we also know is that during the pandemic and during the waves of the pandemic, we have seen less heart attacks come in the hospital early on. And of course, this doesn't mean they didn't happen, but what it means is that people were so cautious going inside the hospital, calling for help, and they just stayed there at home and just put up with the discomfort. But then the problem is, then they came in, and first of all, they came in late, so the door-to-balloon timers would say the time it took from getting the artery blocked to getting it open was much longer. But also, many patients came with out-of-hospital cardiac arrest. So they didn't come on time as they would have at other times, and as a result, we did have many more heart attacks and that were missed, and then the patients had cardiac arrest, which has a very, very high mortality. Similar thing in Italy, the same thing we've seen in New York. The bottom line is, if you have symptoms of heart attack, chest discomfort, shortness of breath, doesn't go away within a few minutes, you don't want to take your chances, even if it's at the height of the COVID pandemic, you're going to ask for help. And this was true especially for the first wave of COVID, but also in subsequent waves, we did see that there was much fewer heart attacks coming to the hospital on time, and as a result, outcomes were worse. We had a lot of impact of COVID on clinical trials as well, because many patients could not make up for their visits. There was difficulty with distribution of the drugs, and moreover, many patients who were on studies got COVID, and COVID can have, as we discussed, high mortality in coronary disease patients, so the outcomes of the studies might be influenced to a large degree, not from the disease we're trying to treat, but from the COVID coming in and causing a lot of morbidity and mortality in those patients. So when you have COVID and heart attack, it is a bad scenario. You're going to have a much higher risk of events, and many patients are going to have cardiac arrest, a lot of thrombus, and the mortality is high. So try to prevent COVID is of utmost importance, especially in patients who have coronary disease. But what happens if you do not have coronary disease? You're fine, your heart is fine, and you do not have COVID? Well, it turns out you still have a lot of problems, and the problems are with lifestyle. I'm just finishing up seeing patients in the clinic in the morning. I can tell you pretty much everyone except for one patient had gained weight during the pandemic. Some people gained a little, some gained a lot, and everyone said the same thing. It was a combination of stress, not being able to go out, the gyms were closed, so that can have adverse impacts on multiple scenarios. This is actually a study of a sample from the entire US, and it turns out that almost half, so 48% of the people in that study had a weight gain. So 1 in 2 Americans actually gained weight during the pandemic. So if you did gain weight as well, guess what? You are with the majority. But there was 20% of people who actually lost weight, 18% to be more accurate. So it can happen. So the pandemic doesn't necessarily mean you have to gain weight, although activities can be slashed. At the same time, you may get extra time if there's another COVID wave, knock on wood. For example, to exercise, if you don't go to work but you work from home, that frees you time from the commute you can use for potentially getting exercise. Also, there has been an increase in things like smoking, as well as alcohol consumption, due to a combination of the stress of the pandemic, restrictions, wearing masks. And that's part of the things that one wants to address early on. And again, now we're kind of a hiatus of the COVID pandemic, so this tends to be forgotten, but it is possible we may have another wave, and trying to control tobacco, alcohol use can be very important. How about exercise? You would think that maybe because of extra time, you might have extra time to exercise, but turns out it's the other way around. And it turns also out that if you don't exercise in the COVID world, and then you actually end up getting COVID, this can be much worse than if you do exercise. So why don't you exercise? Many reasons, including stayed at home, the economic collapse, the gyms were closed. But then see what happened if you got COVID-19 and you exercised. Well, if you exercise, your risk of having hospitalization was much less. So if you're in good shape, even if you get COVID, you're going to do much better than if you are not in good shape. So those who were consistently inactive had much worse outcomes than the ones who were actually active and exercising. How about going to the unit? So it's one thing to go to the hospital, but what's even worse is to be so sick that you're required to go to the intensive care unit, required to be on a ventilator for a prolonged period of time. Well, guess what? It was the exact same finding. The more active you were, the less likely you were to end up on a ventilator. And then the same was true for dying. So if you exercise and you're in good shape, you're less likely to get COVID, you're less likely to go to the hospital if you get COVID, less likely to get intubated and in the intensive care unit, and you are more likely to survive the event. So it does have a great event, and that's actually completely under our control. Some things, for example, if you're going to contract COVID or not, it's partially in our control because you make it exposed to people, and there's only so much you can do with masks and distancing. But the exercise, this is something that is 100% under our control, because no matter what the situations, this can happen. How are we now with COVID-19 and coronary artery disease and overall? It's been, again, a lot of disease all over the place. Half a billion people all over the world. In the US, it's almost 1 million people who've died from COVID. So it has been a lot of impact. And again, now we're on this plateau where the cases seem to have weaned off. So we're in this nice window. But what the future brings, we don't know. Don't forget, 2 months ago, we did not have any ICU beds because of the COVID patients who required prolonged ventilation. So the future is unknown. But there are things we control, and what we control is what we do given the circumstances, whether in a COVID wave or not. And what are the things we can do is, first of all, to get vaccinated. You've heard from the NACMI presentation. If you're vaccinated, you're much less likely to get COVID. If you get it, you're much less likely to have severe disease. We can still try social distancing. I know this is going away now with airlines allowing travel without masks, but depending on the scenario, that might be still a useful thing. Exercise is critical. Again, less likely to have adverse events if you're in good shape. Same for smoking, same for your diet. Try not to gain the weight through exercise and controlling your diet. Sometimes it's actually better to not listen to the news too much. Be informed. At the same time, being over-informed can be a negative thing, creates more stress, and that can feed into more eating or less healthy habits like smoking or alcohol consumption. So listen to the news, but within moderation. There's no need to know everything that goes wrong in the world. And finally, if you have coronary artery disease, don't miss your visit. Many patients did not come for regular follow-up, and then we ended up having a lot of issues, especially true if you're having symptoms, if you're having chest discomfort, other problems. You don't want to come with a heart attack late to the hospital. Much more damage to your heart, you're much more likely to have an adverse event, and it's just poor all the way around. Get vaccinated, especially for coronary disease patients, and then keep on doing the same things you know are good for you. Exercise, eat well, don't smoke, and take care of your heart. So I'm going to stop over here and then open to questions. I know there are many questions that are coming, and anyone who is live right now, please feel free to ask any questions. We'll do our best to answer them within the next few minutes.
Thank you, Dr. Berlakas, and also Dr. Garcia for sharing that excellent and informative information with us. We do have some questions that have come in. We've got a variety of them here. And Dr. Berlakis, thank you for taking the time to answer them. The first question that's come in, is there a particular age that one should see a cardiologist for a preventive cardiac checkup? Or are there things that we should have our primary care physician screen us for cardiac disease?
Yes, thank you. So great question about seeing a cardiologist. So everyone should have their cholesterol screened. So that's the classic follow-up. If you go to your primary care provider, you want to check the cholesterol, you want to check the blood pressure. These are simple things. We do know that the higher cholesterol increases your risk of heart disease, high blood pressure increases your risk of heart disease. So this can be done and should be done pretty much everyone who visits their primary care provider. Now, when do you see a cardiologist? I would say if you have a strong family history of coronary disease, it's probably a good idea, or any heart disease, to visit a cardiologist sooner rather than later. So a strong family history will make you go a little sooner seeing a cardiologist. Second, if you have symptoms. Now, quite often, let's say you have some chest discomfort, some shortness of breath, many patients will first go to their primary care provider and then they will come to a cardiologist. But this is a time, if there are symptoms, we want to make sure that there is no cardiac disease being involved. But always good to catch it early, so follow your primary, do your screening with blood pressure measurements, cholesterol measurements. That will go a long way to prevent heart problems down the line.
Thank you. You talked in your talk some about diet and exercise and how the pandemic has impacted that in people. Can diet and exercise alone reverse heart disease to any degree? And at what point are medications or surgery a necessity?
Yes, thank you. And actually, this is something that there's a lot of misinformation about. How can you just take care of yourself and reverse heart disease? And there are many case reports, anecdotal cases series where patients who follow a very strict lifestyle can actually see the blockages in the coronary arteries actually get less severe over time. There was a study by Dean Ornish, so it's a very famous study done many years ago, showing that with diet, exercise, stress management, actually you could see less atherosclerosis in the coronary arteries. Now, having said that, that's very hard to do. Is it possible? Absolutely it is, but it's not an easy thing. This is not just walking 30 minutes. This is like serious exercise, walking for a long period of time, having a lot of exercise, very strict with your diet. But with a combination of good lifestyle habits, diet, exercise, taking your medications, you can definitely kind of slow the progression or freeze the progression. And in some cases, yes, it is possible to regress your coronary artery disease.
Thank you very much. Another question, one of your top notes up there to take care of your heart is vaccination and getting vaccinated. Do you recommend boosters for everyone? And do you have thoughts about the second booster?
Yes, thank you. So that's, again, a question that is a little controversial, especially for the second booster. I think for the first booster, most people should get it. Again, it does increase your protection, especially if your first dose was with the Johnson & Johnson vaccine. And then with an mRNA vaccine is the preferred one as per CDC guidelines. The second booster is definitely a good idea for people who are immunocompromised, who may have a poor response to vaccines in the second place. I must say this data is still kind of evolving regarding its utility overall. So it's something that is kind of not clear at this point. Could it help? Possibly. It looks like the protection is not quite as good as the first booster gives you, but again, something definitely to consider down the line.
Thank you. Can you talk a little bit about risks for people with hypertension who get COVID, and if you know any differences between those who are vaccinated and unvaccinated?
Yes, great point. And again, it's well established that if you have hypertension, you are more likely to have worse outcomes with COVID. You are more likely to go on the ventilator, have worse outcomes with presentation of the disease. It may have to do with the receptors that the virus is using to enter into the body cells. Again, the mechanisms are still being evolved. But yes, hypertension is one of the risk factors, and that is why, similar to if you have coronary disease, if you do have hypertension, that's an extra reason to become vaccinated. The consequences of getting COVID, if you have hypertension or coronary disease, are much worse than if you don't.
Thank you. Dr. Garcia had talked about the NACME study. Are there other areas to be explored in the NACME study that you're interested in?
Yes, so there are many other areas, and again, this is just the preliminary, but let's not forget NACME is actually an ongoing registry. So we're seeing live the evolution of COVID and its impact on heart attacks, in the United States and beyond. So yes, there are many things to be explored, associations of how people present, how their treatments may change over time. Are we seeing less thrombus formation now? How it actually happens in people who have been vaccinated and still get COVID. So there are many unknown factors right now that we're still exploring. So yes, NACME will go on and hopefully will give us more answers in the coming months and years.
Thank you. Going back to the exercise question, how much exercise per day do you recommend?
As much as you can, but the answer is, the recommendations from the societies are fairly, I would say, pretty minimal. They say, you're supposed to exercise in about 3 hours a week, but I would say a minimum is half an hour a day. So if you can exercise half an hour a day, walking, whatever exercise you do, that's the minimum. But in my mind, the optimum is much more than that. It's always, I find it fascinating. People who have had coronary disease, had multiple stents, had coronary bypass, and they don't exercise at all. I mean, if you have coronary disease, this is your medicine. This is like taking your pill. This is something, if you do it, you're going to live longer and healthier lives. So in my mind, half an hour is the minimum, but I would say if you do an hour or more, that's better. It doesn't have to be concentrated. People think, I have to go to the gym and do an hour of treadmill or lifting weights, whatever. It doesn't have to be. You can, maybe you can walk 20 minutes in the morning, you can take up the stairs at your work, you can work in the afternoon, then you can do some weights later on. So it doesn't have to be all done at once. This is cumulative. And many people like to use the devices like smartwatches and track themselves. That motivates them to do the 10,000 steps or 15,000, 20,000, whatever it is. So again, 30 minutes, but an hour or more is better.
Thank you. Has there been any research or documented effects of long COVID on heart health that you're aware of?
Yeah, excellent question. There was actually a large study from the VA system published recently showing that if you have COVID, then in the next year, you'll have about 50 to 70% higher likelihood of getting a stroke, getting a heart attack, getting in the hospital with heart failure. So definitely, even if you don't have heart disease, so getting COVID is not a good thing, and having COVID is bad even for people who have no cardiac disease, and the effects persist for at least a year afterwards. Now, how long they persist? We have patients in clinic who feel very poorly afterwards. They have shortness of breath. It is very hard to sometimes figure out if it's the lungs causing the problem or if it's the heart. But yes, there is a legacy, so to speak, effect of COVID that translates to cardiac events, and that goes for at least a year and probably longer than that.
Similarly, is there any evidence that you know of that COVID has caused AFib?
Yeah, again, this is very controversial. COVID is well shown to have high event rates with the clot formation. Now, given, the AFib can be a non-specific response of the body to a stressful situation. So many patients who've had in the intensive care with COVID, they also develop atrial fibrillation, especially if they have, pre-existing cardiac disease. So COVID can definitely precipitate atrial fibrillation, but whether it's independent of the underlying heart problems, again, that's still being worked out.
Thank you. If people are interested in learning more about the research that you facilitate and lead, where can we find out more about that?
Great question. But, the MHIF website, the Center for Complex Coronary Artery Disease, CCAD, is on the MHIF website. And then, we do have a lot of education for physicians and for patients there as well, Progress CTO manual, PCI manual. So there are many, many options online. But I would say MHIF website does provide you a good overview of this presentation, other presentations and around a lot of education related to heart problems.
Thank you. And then our final question, what are you most excited about regarding the future of coronary artery disease research?
Thank you. So that's a little broader than COVID, but I think actually COVID helped us kind of mature to some extent and be more flexible in how we deal with adversities and on how we tackle coronary disease. Again, we saw that, the coronary disease is an ongoing process. It's not going to go away anytime soon. And with the lifestyle, diabetes, obesity, less exercise, it's going to be growing. And the circumstances we're treating coronary disease are going to be tough. So what excites me about research in coronary disease is, first of all, the prevention. I mean, the exercise, diet, all the things we talk about that are hard to do, finding creative ways to get people motivated to do the things that everyone knows is good for you, but it's hard to implement. So implementation science, I think, is going to be a lot of technology involved, a lot of online videos, online classes, the smartwatches, a lot of ways that you can get motivated to do things that are going to be good for you. Also, a lot of research on how to be more efficient and have the patients not delay care when they need it. I think a lot of research on how to make people less afraid of reaching to medical system if they have a problem. Many people, including some young people, would have much better outcomes if they had called 911 a few hours earlier than they actually did in the next few days. And then we do have a lot of new techniques and technologies to take care even of the complex coronary disease. So even with people who, for various reasons, lifestyle, genetics, they do have very complex coronary disease, we can now often, through a combination of percutaneous techniques, surgery, get a very good result and make them live longer and healthier lives.
Great. Thank you very much. And thank you for your time. Do you have any final words you'd like to share today?
No, thanks again. Thanks everyone for being a part of this webinar. Thank Dr. Garcia again for an excellent presentation of NACMI. And any questions, please feel free to reach to us and we'll be happy to answer them offline as well. So thank you so much.
Thank you. Thank you, Dr. Berlakis, and thank you to all of our attendees for joining us today. Please do make sure to register for our upcoming On the Pulse sessions featuring Drs. Ritu Saxena and Jason Gupta. Registration information will be made available via a follow-up email that you will be receiving later. Thank you again and have a great day.